Okay, so welcome everybody. Ali Madad. It's a beautiful, glorious Sunday afternoon, and we're spending some time together to understand the menopause. I'm Shaynaz, and I'm a board member with the Aga Khan Health Board, and we are very pleased to be in partnership with the Women's Activities Portfolio led by Shaynaz. And this is the second of our hormonal health series. Brought to us by Women's and the Health Board. So I'd like to hand over for a brief few moments to Shaynaz, who's going to welcome us all today. Shaynaz.
Thank you, Shaynaz. Yalandud, everyone. I think Yalandud is a big, wide Yalandud today because we've got people from the UK as well as from outside the UK. So thank you very much for joining us today. I'm the National Council member for WAP, and for anybody who's not been to a WAP session before, the Women's Portfolio is really focused on supporting women throughout their lives and helping you in your journey throughout being you, being a mum, being a wife, being a sister, being whatever you are, in all of the roles that you play. And a big focus for us is really empowering women to make lifestyle choices and giving you really essential information to help to you to look after your well-being and your lives. And so this is a real great topic that we were able to bring with our speakers today, and we will introduce them shortly. So before we do that, just a big thank you to our speakers to be able to bring this kind of information to you all, and we hope you enjoy the session. Thank you.
Thank you, Shaynaz. So our topic today is hormones. We want to understand what our bodies do, and we want to think about the ways in which we can be more aware of our bodies, begin to support our systems, and prevent associated health issues in the future. So this is very much about taking a holistic approach and to understand the story of menopause with Farah, who is a functional naturopathic nutritionist, and to understand menopause and HRT with Dr. Shaynaz Jivraj, who is our consultant obstetrician and gynecologist. Now, of course, they'll both be sharing information that they have and expertise that they have from their professional qualifications and their work with various women. So I'm going to hand over to our speakers in just a moment. I'd like to check in with both of them, make sure they're here and they're happy. So I will start by saying hello to Dr. Shaynaz Jivraj. How are you this afternoon rather?
Hi, Ali Madad. Fine, thank you. Hope you're good too, Shaynaz.
Good, thank you so much, Dr. Jivraj. And tell us, you've been working in the field for how long now?
So I've been doing obstetrics and gynecology since 1997. I'm afraid it does take a few years to get trained to be a consultant.
Got you.
And I've been a consultant for the last 11 years and an expert in the menopause, having acquired advanced accreditation from the British Menopause Society. Amazing. In 2016.
Wonderful. Yeah. So we're really looking forward to hearing from you. First, we're going to hear from Farah. Farah, how are you doing today?
I'm very well, thanks, Shaynaz. Warm, but still keeping cool.
Fantastic. All right, so I'm going to hand the floor over to you for the next 20 minutes or so. We're in your capable hands. Take it away, Farah.
Okay, I'm just about to share my screen, so bear with me because sometimes it takes a little while to load.
All good. Off you go.
Great. Fantastic. Great. So just a little bit about myself. I studied to be a naturopathic nutritionist for 3 years. So it was a very intensive course to understand how food and supplementation affect all the organs within the body. I've since worked with several women who've gone through menopause, and through the presentation, you'll find that I'll be giving anecdotal information of how I myself was able to get to a really strong point without suffering some of the symptoms that some of us suffer in a really, really severe way. So this is about the story of the menopause and how hormones affect everything. Some of you may have attended our endocrine system hormonal health seminar prior to this one. And obviously you'll have a certain foundational background to understand how organs and hormones work together and which organs produce what hormones. This one is going to be focusing much more on the menopausal and female hormones. I wanted just to say that this presentation is for general guidance, as everybody is different, both genetically and physiologically. And always, if you're going to get the best results for yourself, the best thing to do is either contact a registered functional naturopathic nutritionist or a medical practitioner such as Dr. Shaynaz, who's a consultant gynecologist who can advise you accordingly to suit your needs. So let's talk about the menopause a little bit. What is it and what isn't it, and what could it be? We'll talk about what happens and what to expect and some of the symptoms that you might be struggling with. We'll talk about some of the associated health risks. We'll talk about natural, medical, and combined approaches, which is the functional part of my job, which means that I'm able to look at DNA and bloods from the functional naturopathic perspective to then say, these are the things that would suit you best, produce a plan. Any functional nutritionist who's registered should be able to do the same thing. Foods to include regularly that are scientifically known to help. So they are foods that have had scientific studies done on the compounds contained within the foods themselves that are proven to help certain types of symptoms. So there'll be vitamins and minerals that are needed in order to help you with those symptoms that you're struggling with. So we'll talk about that, natural vitamins, minerals, and supplements. And we'll also talk a little bit about the lifestyle and the impact that DNA has. And that's the functional part of what we're going to be covering today. So just a little bit of lightheartedness, but also just recognizing what menopause might look like. Well, does it look a bit like this to you? Your estrogen levels are going up and down. You've got night sweats. You feel uncomfortable. Some of you may already have been diagnosed with osteoporosis. You've got hot flushes. Your periods become irregular. So you get cramps and mood swings. So all of these things are natural causal factors of going through perimenopause to menopause to postmenopause, and usually tend to settle down postmenopause. It might feel a bit like this, and this is light-hearted fun, but I think we can all relate to feeling a bit more itchy and maybe a bit more moody and, you know, a bit more sweaty with the hot flushes. Sleep and sleep disruption, a little bit bloated. Oh, my stomach's always bloated. And of course, all of us, I know that my friends and I always complain about this forgetfulness that we get during menopause. So that's a symptom that a lot of women talk about to me. I'm just going to do a small reminder of some of the facts that concern menopause, and that's that women in their late 40s or early 50s experience it, unless there's an underlying condition or reason for it to be earlier. The average age of women who are going into perimenopause and menopause is around 51 by the data that is currently given. Perimenopause is the time leading into your menopause, and that means you're still having irregular periods and all of the symptoms. Your menopause is when you've been period free for 12 months. So that means you have had no menses and no bleeding for 12 months. Postmenopause is after that 12 months, where your body is still producing hormones, but you have no menses at all. During the cycle of perimenopause to postmenopause, you will see that there are changes in your body and those symptoms that arise as a result of the whole process. Menopause can increase the risk of osteoporosis. It can cause vaginal dryness and weight gain around the belly, but those are not things that need to happen. So when we go through the food and supplement elements of the presentation, you'll see that there are things that you can do to help that from becoming a problem. And just a reminder that each person will experience menopause differently. So it is very much a personal journey, but the good news is that we're all in this together. You know, all women get it, and we can talk about it, and we can help each other through it. So what is it? What isn't it? And what can it be? So what it is known as the change. So you're changing. Your body is changing. Your hormone levels are changing. The eggs, which are a finite number that you're born with in the ovaries, are finished. There are no more eggs being produced. And then your menstruation stops. What isn't it? It isn't a health problem or an illness, unless you've got other conditions underlying or separate to the menopause. It isn't a sign of old age by any stretch of the imagination. It isn't the end and doesn't have to be the end of your youth and vitality. And it isn't unmanageable, because through dietary changes, through lifestyle changes, and through supporting changes, you can actually make it what it can be, which is freedom from menstruation and birth control. Finally, we don't have to think about that monthly period coming to us. A transition to an active and liberating and re-energizing phase in life, which means that you can do things that perhaps before were a little bit difficult, but now you don't have to think about your menses all the time and what's happening to you. And lifestyle and nutrition, spiritual choices is a really big one for me. And we're so lucky that we're part of a community where that is a focus. It can help you to age in a strong, stable, and well way. What happens in those stages? So stage 1 is perimenopause, so the transitional time before menopause, and it's the 12-month that follows a person's last period. The menopause starts 12 months after the last period, or when menstruation has stopped for clinical reasons. So, for example, you may have had a hysterectomy, or you may have had a partial hysterectomy, which means removal of ovaries, or you may have underlying health conditions that may have caused the stopping of your menses slightly earlier. Postmenopause obviously refers to the years after menopause, and although it can be a little bit difficult to understand when that's finished, this doesn't mean that your body stops producing hormones. Menopause doesn't mean that your body stops functioning as a woman. You still have hormone production going on post-menopause. This slide I'm sharing just for a visual, and I know Dr. Shaynaz is going to be talking a little bit more about this in detail, so I'm not going to focus too much of it. But you can see that it's between the ages of 35 and 60 where the estrogen dominance risk period is. What does this mean in very simple terms? It means that your estrogen starts to rise and your progesterone starts to go down. And I think that because Dr. Jibraj is going to be talking about this at length, if we can wait until she does this from a medical perspective, you'll understand it a lot better. So let's talk about the main effects of estrogen and progesterone hormones. I think we all know that we have estrogen and progesterone. And if you look at estrogen, what does estrogen do? It builds up the uterine lining. So that means it builds up the lining and then it sheds it every month. And that's when you get your menses. Estrogen also helps increase body fat. It can have negative effects. So if you've got a lot of estrogen surges, then you can get migraines and headaches. It can interfere with thyroid hormone, but it also increases blood clotting, decreases libido, impairs blood sugar control sometimes, depending on what you're eating and how your hormones are functioning together with all the other hormones. Can, if there's too much estrogen in your body, increase the risk of endometrial cancer and breast cancer. Progesterone maintains the uterine lining. So if you're pregnant and your progesterone levels aren't high enough, for example, you can miscarriage. It was one of the things that I struggled with. I personally had 9 miscarriages and a stillbirth. And at the time when I was going through that, I didn't actually have the knowledge that I have now. And although I went to several different people, it never resulted in a live child. So now that I know all of this information, it gives me the ability to be able to help them and understand what they can do to help themselves in that area too. It uses fat for energy. It's an antidepressant. It's a very positive hormone, and it also helps to regulate blood sugar levels and protects you from several other conditions. In terms of symptoms, what you might feel and what you might see in terms of the organs and how it's related. So you might feel a sense of weight gain and heavy night sweats. You might get headaches. You might get psychological problems in terms of dizziness. A lot of women in menopause struggle to sleep. They get a little bit depressed. They transition from the menopause and menstruation. They can be longer or shorter cycles. So it could be that you don't have a period for 3 months and then you have one. And then you've got things like joint soreness and stiffness, back pain, sometimes itching, and all the things that we saw in the slides prior to that. So what can happen to you during this time? Well, you can a lot of people are on calcium supplements, and they're taking those supplements to actually protect them from bone loss. That's as part of the reason as estrogen declines. That's one of the things that you can do, and you can lose up to 20% of your bone loss, density of your bone after the menopause. Not everyone has osteoporosis as a result, but fractures can happen more easily. The brain function, well, you get a little bit more forgetful, and women may develop Alzheimer's as they age. Early research suggests that women tend to get more prone to it than men do. During menopause, you can feel up and down, sad, moody, and mood swings are not something that are not manageable. Again, all of these things that can happen to you are things that can be managed through changes. Poor sleep, as we've already discussed, but women between the ages of 40 and 64 really struggle to sleep, and their sleep routine changes. And there's something called in the holistic world a sleep cycle, which again can be managed through the way that you change things through your lifestyle. Bladder issues are uncomfortable, but there are things you can do about that. And then you've got heart disease. Now, menopause doesn't cause heart disease, but there are certain things that can increase the risk to heart disease that are happening through menopause. I know I discussed this at length with Dr. Shaynaz, and she's going to kind of cover that with her information. So now I wanted just to talk about hormonal replacement therapy from a holistic point of view. So this is not the medical point of view, which Dr. Shaynaz is going to cover, but the holistic point of view. So there are certain studies that are saying that there are risks, and I know that that's going to be covered a lot more from the medical perspective. And all I'm trying to do from my perspective is saying that you could choose, you have a choice, and knowledge is power. So you can combine in a functional way to use medicine to start with to rebalance you, and then support that with the natural options that you have. So it's not just about saying, well, I'm going to do this or that. It's about saying, actually, we can work together to give you the best possible outcomes and allow you to age in such a way that it is all of those things that it can be on that slide, rather than the things that it isn't or it doesn't have to be. The Cancer Research UK guidelines on HRT are clear. I don't have to read this slide to you. There are risks and there are benefits. The clear thing from a holistic perspective is that if you are talking about the risk versus the benefits, then why would you take the risks if you can manage it in a natural way and you don't have to take hormones? However, there are certain people who have got to such a stage that they need to be able to take the hormones to bring them back to a place where then they can be supported by the lifestyle and nutritional changes. There are some lifestyle tips that are really simple. And if you can do this starting from tomorrow, then you will see immediately that there is going to be a difference. So eating the right things 80% of the time, and 20% of the time eating what you fancy, which is also important for emotional and a feeling of that was a treat and it was great and I really enjoyed it, is going to result in you being able to get better results from your menopausal symptoms. I don't put gym, but I put exercise and movement. The reason why I call it exercise and movement is that it doesn't have to be aggressive exercise. A lot of menopausal women associate aggressive exercise, cardio exercise, as a means of losing weight. But one of the things about looking at your body functioning holistically is that when you're exercising in a way that is aggressive, you're releasing cortisol hormones. And you'll have heard of cortisol, some of you maybe, which is the stress hormone. So what you're doing is by pumping your heart, you're sometimes putting your body, not everyone, this is a general thing, but you're putting your body into fight or flight mode, which means that you're in stress. Now that works for some people. However, in menopause, it's much more relevant to look at weight-bearing exercises. So then your bones stay strong and your muscles stay strong. If your muscles are strong, then you've got protein, which is using up calories without you even doing any exercise. You can do Kegel exercises for your pelvic floor. So we've talked about incontinence, and maybe, you know, when you cough or you sneeze, you lose a little bit of fluid. That doesn't have to happen. The Kegel exercises, if you look them up, are very easy to do by yourself at home. And it means that you can actually go out without having to feel like if you cough or sneeze, it's going to become a problem. Yoga, Tai Chi, Qigong, they're all related very much to spirituality, meditation. So if you're thinking about the way that we do our religious prayers in the morning, Bungi, then that's a type of meditation that can actually bring your stress levels down, your cortisol levels down, and allow your other hormones to stay balanced. Anxiety and stress management, there is so much help today. And if you do feel anxious or you're suffering from stress, then, you know, seek counseling and support. This group of women WAP have women's groups that you can actually contact. And so, you know, there's a lot of strength in asking for help and seeking help and getting help, because that puts you in a positive frame to change the outcome for yourself, and taking control of that also makes you feel really positive. Why I talk about sleep so much is that when you sleep, it's when your body uses the time to repair the things that are going wrong. So sleep is crucially important. And when we talk about the supplements and the food, we'll be talking about the compounds that actually help your body to relax, and the things that you can do before you go to sleep to help you get a good night's sleep. Recreational activities. Some recreational activities, I don't have to really talk about which, can lead to further issues. So therefore, try to understand what they are, and therefore committing to taking actions to avoid them is also going to help you in so many ways to actually keep your hormones rebalanced. Intimacy is not always about, things. You can explore intimacy with your partner in terms of hugging and cuddling and all of those sorts of things. So it's not something that has to become a problem either. One of the main issues that women actually really struggle with is weight gain during menopause. And we have already talked enough about the lack of sleep, the increased levels of stress, not getting enough exercise or movement, the right type of exercise and movement, the changing of the hormone levels, and the poor diets and hormone control. Now, I know everybody's not eating chips and burgers and hot dogs, but equally there are things that you can avoid that will give you the ability to be able to eat the right things. I know that Dr. Shaynaz is going to be talking about isoflavones, lignans, communistands, and seeds a little bit more in terms of medical compounds, but just to give you an idea of things that actually do work, these are certain compounds in food that actually help you in terms of rebalancing your hormones. A lot of these have had studies done on them, not on the food itself, but the compounds that come out of the food when you chew and digest and absorb them in your stomach. Now, this one is something that I produced, and I hope that you will print it out and basically stick it on your fridge. You've got vitamin E. So vitamin E is renowned for helping with hot flashes, overall skin lubrication. So as your skin is drying through the menopause because of the hormones going down, and it also helps with hormone balancing. So vitamin E is a crucial one. Fatty acids, you might ask me what they are, omega-3 and omega-6. Now, a lot of people take an omega-3 supplement already, but they might be taking too much omega-3 and not enough omega-6. The ratio between omega-3 and omega-6 needs to be 4:1. So 4 times more omega-3 than omega-6. Omega-6 is things like nuts and seeds. Omega-3 is things like salmon, fish, etc. Vitamin C is also a really crucially important one. And you've got bioflavonoids, which actually help with hot flushes. It's also really good for oxidative stress, and stealing the, so if you've all heard of antioxidants, which are usually in the form of berries. Most people say, oh, they're antioxidants. What that means is that those fruits are actually giving you the ability to create oxygen molecules, which means that when you're under oxidative stress, the oxygen is not being stolen to stabilize other compounds in the body. Magnesium is crucially important for 2 reasons from a holistic perspective. It helps with calm, it helps with sleep, it helps with headaches and mood swings and anxiety, even with constipation. It helps with around about 300 bodily functions. And it also helps with absorption of calcium. So more recently, there have been some major studies talking about magnesium and how if you're taking calcium supplements, magnesium needs to be a part of that so that it helps to get the body to absorb the calcium into the bones, therefore your bones staying stronger. I know certainly it's helped me, and even with my mother who's 80, she's had osteoporosis and she's taking magnesium supplement, and it certainly helped her with her bone density. Menopause supplements and creams, again, there is obviously hormone creams that you can use, and there are natural versions of that or chemical-based versions, medical versions. The natural versions that you can get are usually extracted from yams or soya, and I mean real soya. So yes, estrogen creams and testosterone creams, and Dr. Shaynaz and I have been talking about the testosterone creams, and I think she's going to be sharing a little bit more about that. There's some really interesting research on that recently that I'm fascinated with, and I hope to have a session with her separately. DHEA is another one, and it helps moderate tiredness and the ability to cope, but again, it's quite a strong supplement, so it needs to be given under direction rather than just picked up and taken, because it can have negative effects. And herbs like black cohosh, valerian. I know that some of you probably have heard of ashwagandha. It's quite popular out there on groups, menopause groups. All of those are great, but again, they have or may have contraindications with other things that you are already taking. So there needs to be caution in the way that you take these supplements. So although they're out there and available, it's always good to seek professional advice from a medical practitioner or a functional practitioner in nutrition or otherwise, to get the right balance for you and to make sure that you're not causing yourself any other issues. Milk thistle is a great one that gives you liver support, and when your liver is functioning adequately, it makes it much easier to get rid of excess estrogen. And St. John's wort, I think a lot of people have heard of as well, and that's a really useful one for depression. Now going into a little bit about nutrigenomics. So nutrition has changed quite substantially since I graduated 3.5 years ago. And the reason why it's changed is because now there is a real sense of actually your genes and what you eat are totally connected. So maybe about 4 or 5 years ago, there was a buzz thing going around saying you are what you eat. Nutrigenomics is the scientific evidence and proof that you are actually what you eat. So the study, what it is the study of genes that directly identify a person's individual susceptibility to things like obesity, but also other conditions in an unfavorable environment. What does that mean? That means you are creating an environment where you're putting the wrong nutrients in, not enough nutrients in, or very bad nutrients in. And so if you are predisposed genetically to something, it's likely to switch on that gene so that you then develop that condition. They can be regulated. These genes help to regulate the way you use energy, the way your appetite is, fat metabolism. So in other words, how does your body break down the fat, and therefore are really crucially important in weight management. And they explore the way in which a person directly responds to certain types of food and certain types of exercise. What it does for a professional functional nutritionist is that it allows that person to individualize a plan for an individual that is sustainable and can offer you a lifetime of good food choices to suit your individual DNA. So it's not a do a keto diet or do a cabbage soup diet or go on a Mediterranean diet or do this or do that. It's actually individualized by your genes. I'll give you an example of that very quickly. I've always believed that I personally fare much better and do very well on a high protein, good fats diet with very little carbohydrate. Now there's a huge trend of people cutting out carbohydrates completely. We need carbohydrates. So because of the knowledge that I have, I've now been able to select the correct carbohydrates that I need for my body, because I've done my DNA diet test. And I now have evidence that I don't have one of the genes is missing completely that actually allows my body to produce an enzyme that helps to break down carbohydrates. So this is why I fare better personally. Having said that, my husband did his, and his came out as the standard balanced Mediterranean diet. In the holistic world, we do DNA testing and other health testing that is perhaps not available on the national health. So I'm only really going to cover the DNA, estrogen and diet, but there is a further test, which is the DNA health, which is much more advanced. And I'm not going to cover that today because it's not part of this. The ability to identify the genes that can be switched on or off are based on dietary and lifestyle changes. So knowing those genes means you can actually get a specific way of eating that really, really helps you to stay well and stay strong. There are other tests that functional nutritionists will use. So they'll use a comprehensive blood test, hormone panels, which is a full hormone panel called a Dutch panel, vitamin and mineral level testing, or stool and urine testing to see what's happening when you're getting rid of your getting rid of your estrogen hormone. Sorry, apologies. And then you've got the natural thyroid temperature method, which again is a way of identifying whether your thyroid function is working properly without having a test. It's a temperature gauge, and all you're doing is you're taking a temperature over 5 days. But obviously, if you're interested in that, there's a methodology that actually works, and that will help you. So any more information about any of those things, you know that you've got WAP and you can ask questions. Please remember that most of these tests are individualized, not available on the NHS, and private fees are usually payable. Please remember that the contents of this presentation are actually firmly based on scientific evidence, and remember to consult with someone who's professional, who knows what they're doing. To leave you with just a little bit of hope, I was hoping to play a video, but the time's run out. What I want to do is show you a picture of what I used to be like in 2016 and what I'm now like, having turned 53 in 2020. This is management of what I eat and lifestyle choices and changes that I have made that have enabled me to go from what I looked like in 2016 to now. And this is evidence of the fact that when you actually apply those things, then it can work. So don't be without hope. Remember that it's possible. Not only have I done it, but other women like me who have consulted with me have done it and have consulted with professionals. So retain your hope. All the very best. Thank you for listening to me. And now I'm going to pass you over to Dr. Shaynaz Jivraj, who is going to be talking about, consultant gynecologist, who's going to be talking about the menopause from a medical perspective. Dr. Shaynaz, over to you.
Thank you, Farah. Knowledge is power. I quite like that. And I already feel more knowledgeable than I was about an hour ago. I think if you ran a Nutrigenomics test on me, you'd probably find my Kadi Khichdi gene is active.
Kadi Khichdi is very good for you, by the way. It's one of the healthy things you could eat quite regularly.
Okay, Yali Madat, everyone. It's an absolute delight to be able to share information with you and connect with you on this bridge to my brothers and sisters from the UK and from the rest of the world who've joined today on this webinar. Farah gave us a very interesting presentation on her professional aspect of managing the menopause. And I think this is extremely important. It's extremely important to actually be able to do that. Why? Because, first of all, I think we're all living longer. This is a graphical illustration of life expectancy as it has changed over the years from 1841 to 2011. So on the y-axis here, you see life expectancy in years, and on the x-axis is the year that life expectancy, the average life expectancy was measured in. And in 2011, for a woman living in the Western world, this purple graph here represents female age. The average life expectancy in 2011 was between 80 and 85 years. If you go back 100 years, let's go back to 1911, the average life expectancy was anywhere between 50 and 55 years. So certainly, alhamdulillah, we have been blessed with longevity. Longevity has brought with it its challenges. One of the challenges is managing the menopause. Why? Because as lifespan has increased, the average lifespan of the ovary has remained the same. It is still 50 years, 50, 51 years. So in 2011, the average age of the menopause was 50, 51 years. The average age of the menopause 100 years ago was about the same. 100 years ago, a woman would be fortunate to live 5, perhaps 10 years into the menopause. Today, if we're fortunate to live our full life expectancy, then we could be spending a third of our lives in the menopause. So we have to deal with this challenge, with this blessing of longevity. And what I would like to do today is, having heard about what can be done from a non-medical perspective, I would like to speak to you about the role HRT plays and what best practice guidance we have from specialist societies like the National Institute of Health and Care Excellence and the British Menopause Society. The idea is not to promote HRT, far from it. The idea is to give you the tools with which to make your choices so that you are empowered to do what is right for you. And one of the tools that is widely available is HRT. And there has been a lot of information and misinformation about HRT in the popular press. So what I would like to do today is just give you a little bit of an update on what we know about HRT, the pros and cons, and how it works today, so that you can make your choices if you need to. We know that the central hormone in menopause is estrogen. Estrogen is a hormone that comes from the ovaries. Estrogen receptors, which respond to this particular hormone, estrogen, are widespread throughout the body. We have estrogen receptors in the brain, estrogen receptors in our bones, estrogen receptors in our skin, in our blood vessels, in the endometrium, which is the lining of the womb, in the genital tract, in the bladder, in the vagina. And between the menarche and the menopause, the menarche is the onset of menstruation. Between the menarche and the menopause, unbeknownst to us, our ovaries produce this estrogen, and the estrogen continues to do its work by stimulating all these receptors widespread. And what estrogen receptor stimulation results in is healthy tissue. So estrogen is responsible for adding calcium to our bony material, keeping our bones strong. Estrogen receptors in the vagina are responsible for keeping the vagina strong and supple and healthy. Estrogen receptors in the blood vessels are responsible for controlling temperature regulation. So estrogen receptors continue to do their work, and we are unaware that this is going on in the background until the time comes when estrogen production stops in the ovaries. Estrogen production is there, a little bit is there, because estrogen is produced in the fat of our bodies, but ovarian estrogen production stops. 50% of our estrogen comes from the ovaries. And that's when we start to sense this lack of estrogenic stimulation, and that's when we start to get symptoms of the menopause. Now, experts of the menopause, they divide these symptoms into 3 categories: the short, the medium, and the long-term impact of the menopause. In the short term, something known as vasomotor symptoms. These are symptoms such as hot flushes and night sweats. These tend to affect a lot of people. That does not mean that every single individual who has a hot flush will seek to do something about it. These are symptoms that are commonly experienced by people. And then there are other symptoms, such as mood swings, irritability, loss of memory and concentration, loss of confidence, lack of energy. These are not uncommon symptoms that are reported by women who are going through the change. This is the main indication. This is the primary indication for HRT. It does not mean that everyone who goes through these symptoms should have HRT, but this would be the main reason why somebody would be prescribed HRT. Now, in the medium term, there are other symptoms which affect the genital tract, which have an impact on women. Estrogen receptors are present throughout the genital tract. They keep the bladder epithelium healthy. They keep the vaginal skin healthy. When estrogenic stimulation ceases, you get thinning out of the skin in the vagina, in the bladder epithelium. Thin skin tends to crack. Cracked skin tends to attract infection. And then women suffer from symptoms of urogenital atrophy, that is vaginal dryness, itching, dyspareunia, discharge, vaginal discharge, recurrent urine infections, and even bleeding from cracked and thinned out vaginal skin. And it's not surprising that the peak incidence of urinary incontinence and vaginal prolapse happens in the 55 to 65-year-old age group. And in the long term, osteoporosis is a recognized consequence of the menopause. Everyone's bones thin. Everyone's bones thin as they grow older. And that is why older people are more likely to sustain a fracture if they fall. It's because the bones are thinner. The more the number of years past the menopause, the more likely that bone's thinner. Everyone goes through it. This is particularly important for women who undergo a premature or an early menopause before the age of 40. Because then what happens is a late effect of the menopause, like osteoporosis, tends to happen much earlier in life. Similarly, women who go through an early menopause, so by early menopause, I mean menopause before the age of 40, such individuals are more likely to have early onset cardiovascular disease. And there is a connection between premature menopause and dementia. That does not mean, and let me be very categorically clear here, that while HRT protects against osteoporosis, there is no doubt about that, that's established. HRT given early on in the menopause, in the first couple of years or so in the menopause, is also known to protect against early onset cardiovascular disease. HRT, there is no proof at all that HRT will protect against dementia. Okay? Now, having heard about what symptoms can happen, we've got to ask ourselves, okay, if these are the symptoms that can occur, I've already said not everybody gets them. Who gets what? How many people actually get these symptoms? You know, we're here on a forum today, we're about 100 people. Not everyone will have had those symptoms. Maybe all of our women who've joined the forum have one symptom or another. But one thing we've got to beware of is that we're not alone. We're certainly not alone. And we know this. We know how common this is very much from a survey that was conducted in 2016 by the British Menopause Society. This was a UK-based survey. And what they did was they asked women, what symptoms are you having and how is it affecting your daily living? So what they found was that 70% of individuals who responded to the survey experienced night sweats. Just under 80% who responded to the survey experienced hot flushes. And between 18 and 22% of individuals who responded to the survey experienced unexpected sleep problems such as insomnia and difficulty with memory, concentration, and also unexpected achy joints. But it's one thing having these symptoms, it's another thing actually how it impacts on your personal life. Because you could have a few hot flushes and it does nothing. You carry on with life as normal. That's fine. I'm sure many people go through that, yeah? However, for some, it does have an impact on their own lives. And When asked further, what people responded saying was that 50% of these women who responded said that menopausal symptoms actually impacted their home life. A third said that it impacted the work life. And half said that it impacted on their relationship, with the physical relationship with their partner. So these symptoms may be common. The impact they have can often be profound. Now, in order to be able to understand what can be done about this, let's just look a bit more deeper into the biology of what exactly is going on at that time. As I said, the ovarian lifespan is about 50-51 years. So from about the age of 40 onwards, for about 10 years, you get a decline in circulating estrogen. This blue-green line shows a decline in circulating estrogen. There's also a decline in circulating progesterone, which is another hormone that's produced by the ovaries. Now going to zoom in to what happens during this period of decline, during this steep drop. Because remember, there is a plateau here, there is a drop, and there is a plateau. What we're interested to know is what happens during this drop. Look at what happens to progesterone. So this purple line is progesterone. You see the drop, a smooth decline down till it plateaus. Look at what happens to estrogen. This red line here is estrogen. There is a plateau during our reproductive years when our ovaries are silently doing their work, producing estrogen. Estrogen receptors are being stimulated, and we're carrying on. And then what happens? There is a sudden decline, but this decline is not a smooth decline. It's actually quite undulating. Yeah. It's fluctuating, ups and downs, ups and downs, ups and downs, ups and downs, until it finally settles. Symptoms of the menopause, the hot flushes, the night sweats, the mood swings, happen because of these fluctuations. The aim of menopause management, the aim of support during menopause, is to try and get an individual from this point to that point, to the point of plateau, in as smooth a fashion as possible. That would be the purpose of menopause management. And there are two angles to do this. One is you leave the hot flushes as they are. You leave the mood swings as they are. You leave the night sweats as they are. You do something to be able to deal with them better. And this refers to the psychological therapies, the cognitive behavioral therapies, the mindfulness, the talking therapies, any therapy that makes you better able to cope with the ups and downs. The second angle to take is to actually do something to suppress the hot flushes and to override this fluctuation, to override these undulations, to give a bit of estrogen, and that's HRT, to override this fluctuating level of estrogen so that there is a smooth, steady decline by an external supply of estrogen. So the external supply of estrogen is what HRT is. It allows the fluctuations to be overridden by a supply of estrogen in the bloodstream so that one can bide time while these fluctuations cease on their own. And then after they've ceased, you can come off your HRT. And hopefully by then, there will be a steady state of concentration of estrogen in your bloodstream to be able to stabilize your moods, remove all those hot flushes, and generally go back to where you were. Now, fortunately for us, we have a best practice document we can fall back on to decide what is best to do. This was a publication from the National Institute of Health and Care Excellence, published in November 2015, and it was updated in December 2019. And there are 4 key messages in this document. First, individualized care. This is not a one-size-fits-all solution. Menopause management is not a one-size-fits-all solution. What is suitable for one person may not be suitable for another. What is desirable for one may not be desirable for another. Indeed, what is suitable for one may be a contraindication for somebody else altogether. So firstly, individualized care, and that means give women choices. And one of the choices that has already been given to you is the lifestyle changes that Farah spoke about. The dietary modifications, exercise, all these can help in managing the menopause. However, there will always be some people in whom lifestyle modification doesn't help. And if these individuals then want some prescribable or medication for managing their symptoms, then NICE tells us that offer HRT as a first line in managing vasomotor symptoms. So vasomotor symptoms is the terminology that's used to describe hot flushes and night sweats. And then there are non-hormonal alternatives. Clonidine and antidepressants are used as second line. Clonidine is an antihypertensive that has a UK-based license to treat menopausal hot flushes. Antidepressants tend not to be licensed to treat menopausal mood swings, but they are tried and tested and approved in small doses to be used to stabilize menopausal mood swings. And they have been approved by the British Menopause Society. Now, the reason why NICE says recommend HRT first, then recommend the others, is because whenever studies have been done to compare HRT with the non-hormonal alternatives, then HRT has always fared more effective. Studies have shown that the non-hormonal alternatives work, but they take longer to work. HRT tends to work faster and therefore tends to be more effective. Having said that, just because HRT is used or is offered as a first line, it doesn't mean you've got to try it. No, if HRT is unsuitable, contraindicated, undesirable, then you're welcome to use one of the second line, such as clonidine or one of the antidepressants, and your GP could prescribe those for you. The fourth point that NICE mentioned is vulvovaginal atrophy. This is, atrophy means thinning out, okay? Thinning out of the skin. And here we refer to thinning out of the bladder epithelium, resulting in recurrent urine infections. 1 in 2 postmenopausal women at some point will get a urine infection. Some people get recurrent urine infections, and that's when it becomes problematic. So vulvovaginal atrophy refers to also to thinning out of the vaginal skin, resulting in vaginal dryness, vaginal pain, itching, general discomfort, and even vaginal bleeding. So if a woman experiences these symptoms, and these are not uncommon, 50% of women will experience these postmenopausally, then there are hormonal and non-hormonal options which are not the same as HRT. They are applied as creams and pessaries. They are applied directly to the vagina, and they do not have the same connotations as taking HRT. They are a lot safer than taking HRT. Granted, there are circumstances in which they should not be taken, they should not be prescribed, such as undiagnosed vaginal bleeding, or even for women who've had breast cancer or are on treatment for breast cancer. They should check with their breast specialist before taking any vaginal estrogen. But there are non-hormonal alternatives for these women. We'll go through them in a bit more detail in a bit. Let's just speak a little bit about what HRT is, because that's what this lecture is about. And the idea is that we should give you that knowledge is power that Farah said, give you information about what HRT is, so that you can then decide whether this is something you wish to try or not, whether it's something for you or not. Hormone replacement therapy is what HRT stands for. there is an evolution in the terminology, and you might find that more and more doctors, leaflets, publications tend to refer to hormone replacement therapy as menopausal hormone therapy, MHT. But that's what it is. Essentially, it refers to replacement of estrogen. And estrogen can be given by mouth. Estrogen can be given through the skin as patches or a gel or spray. And you don't need to replace progesterone for your symptoms. The main hormone that you're replacing to stabilize estrogen levels is estrogen. But if you've got a uterus, which most people would, then estrogen can stimulate and make the endometrium, the lining of the uterus, grow. And to prevent that from happening and prevent it from growing excessively and becoming cancerous if it grows excessively, then progesterone is added to prevent that excess proliferation. And your doctor may choose to give you sequentially or as a continuous combined regime. Sequentially is when you have a bleed, continuously is when you don't, when it's bleed free, depending on how far from the menopause you are. And the rule of thumb is you take as little as you possibly can just to manage your symptoms. But you may use HRT for as long as is necessary. There is no upper age limit, provided you're aware of the risks. And there are risks of HRT. And the main risks we have of HRT are breast cancer, stroke, and thrombosis. Now, the one that scares people the most, and not surprising, is cancer. Unfortunately, it's common. This is a leaflet that's published on the British Menopause Society website, and it outlines and puts risk into context. It tells you what the risk of breast cancer is in a pictorial format using HRT. And looking at the background population of women in the UK, then the background risk of getting breast cancer, this is the general population, is 23 new cases of breast cancer diagnosed in the UK general population per 1,000 women aged 50 to 59. Okay? What does HRT do? HRT increases that risk by a bit. So HRT will, and this is combined HRT, estrogen and progesterone, HRT increases that risk by 4 more women. So from 23, it increases it to 27, okay? 27 per 1,000 women aged 50 to 59. And estrogen alone will increase the risk, but less so than if you take estrogen and progesterone. But look at the other things that can increase the risk. Look at the one that I want to highlight to you here is obesity. So if someone's got a BMI of 30 or more, the risk is doubled. A lot more than taking HRT. So this is just to put things into perspective. And you might find that the additional 4 is too much of a risk for you and you don't want to take HRT. And that's fine. Or you might find that actually, you know what? It's only that much. I'll take it for a little while just to tidy me through these symptoms. We spoke about the vulvovaginal atrophy. So the treatments that are available for those conditions are vaginal moisturizers and lubrications and lubricants, and these are completely hormone free. They're available over the counter. Some of these are even available on prescription. And then there are estrogen pessaries and creams, which are available only on prescription, but are very effective and widely available and do not carry the risks that normal HRT carries, namely of breast cancer, like the way I've described. Having said that, like I said, if someone's already had breast cancer, then they should check with their breast surgeon before taking any vaginal estrogen. And there are newer drugs on the market, vaginal phytoestrogens and DHEA pessaries, oral estrogen complexes as well. These are relatively new. The first 2 lines are the tried and tested regimes, and these are the ones I tend to prescribe more than anything else. There is another hormone that that the ovaries produce, and that's testosterone. And testosterone is responsible for libido, and 1 in 2 women suffer from loss of libido, and testosterone gel is available on prescription, but that tends to usually be supervised by a menopause specialist. Just a word of caution about herbal remedies. Yeah? Herbal remedies are not as simple or as innocuous as they may sound. It's not like, taking a twig of rosemary or twig of sage from your garden and putting it into your soup. It's not like that. Herbal remedies are pre-packaged products that are available over the counter. And they are not as innocuous as one may think. One may think that, it's herbal. It's not medication. It's only herbal. It can't do much harm. Let me see if I should try that. Be careful, because there are some herbal remedies that should not be taken with some existing medical conditions. Isoflavones and soya products contain phytoestrogens, which are a concentrate of plant estrogens, not usually recommended for breast cancer patients. Black cohosh, to be avoided with tamoxifen. Tamoxifen is a breast cancer drug because black cohosh will enhance the breakdown of tamoxifen and, in theory, increases the risk of recurrence. St. John's wort, another common herbal, not to be recommended if someone's had breast cancer or at high risk of breast cancer. But if you go down the herbal remedies route and you wish to try it, then I would urge you to look for this THR kite mark. This is the traditional herbal registration stamp. It belongs to the Medicines and Healthcare Regulatory Agency in the UK. And it's a stamp validating the strength and the quality of the product you're buying. So if you buy a product, first of all, look for this stamp and then just be double sure that you don't have any existing medical condition which contraindicates the use of herbal remedies. So my take-home messages today are, the choice is yours. You've got the information, whether you take HRT, you don't take HRT, that is your choice. You've got the information and you've got now the power, okay? The second thing is vaginal estrogen, vaginal atrophy, and the vaginal dryness and pain that women suffer. Undiagnosed, unrecognized, and undertreated. There are simple, effective remedies for this. Do look them up. Do ask your doctor about them. It is completely unjustified to suffer in silence. And finally, lifestyle modifications. This is the diet, the exercise. Even if these modifications do nothing to manage your menopausal symptoms, they are, I think, important to visit. And the reason they're important to visit is that menopause age of 50, 51, 45 onwards is an important milestone. There is a third of our lives, inshallah, left still to live. And moreover, those non-communicable diseases that Mola Bapa speaks about in his firmans, they tend to start to brew at this age. So even if these lifestyle choices do nothing for menopausal management, they will do something in trying to reduce your risk of developing those non-communicable diseases. Okay, thank you, Anyali Madad.
Thank you so much, Dr. Jivraj, and thank you so much, Farah. And we have had a number of questions as we have been listening to the both of you. So you've certainly given a lot of information and caused us to think about the choices that we have. And I do certainly feel empowered to make those choices. So we will stay on a bit longer for questions. But I know that certain people may wish to already give their feedback and perhaps to ask questions anonymously. So please do that by logging on to www.menti.com. And when you get the prompt to enter a code, it's 918111. We really, really appreciate your feedback and your questions. So please take just a minute or two to give those to us. That would be very much appreciated. So we have had a number of questions, as I've said. We've been monitoring the chat, and I'd like to ask a couple of questions of our speakers in the next few moments. But just to say, firstly, that we mentioned providing a summary after today, which will contain some of the nuggets of the information here. And it can also respond to a couple of questions that have come in on the chat. We had a question about DNA and thyroid tests. How much do they cost? How do I access them? We can include that in a summary sheet for you. We can also include reading material Somebody was asking about naturopathic solutions, and things like what was the ratio of omega-3 to omega-6, all these important facts and tips that we've heard. So we will look to incorporate those in a summary and to circulate that round to the group that's here, so you can share those. So I will give you some of the questions in a minute, just to also remind everybody that we are here. So in our last slide that we have up for you, just to remind you that if you are wanting to have a specific conversation about the choices that you're wanting to make, you want to go through some of the things that have been shared with you today, please reach out by phone, by email, and we'd be very, very happy to support you and signpost you to the best place to get your questions answered. Okay, so we will stay on a bit longer now and respond to some of the questions. I'm going to let Farah have a look at the various questions that are coming up about herbal roots. I don't know that we've got time to answer all of them about evening primrose, maqui root, and so on. But if you'd like to say something more about the herbal remedies that are available, and with the cautions that Dr. Jivraj gave us, is there anything specific, Farah, that you would add to the messages that you've given already about, you know, self-service and going to the counter and just grabbing a herbal or a natural remedy? Just unmute yourself.
Unmute. Can you hear me now?
Yes.
Clicked on mute 3 times. The last slide of my presentation was really about taking caution, and Dr. Jivraj and I have had several conversations. I'm a functional naturopathic nutritionist, and most functional naturopathic nutritionists who are professional will work alongside medical professionals to deliver the best result for the individual. Earlier on, I talked about individualization, and I also talked about everybody being different genetically and physiologically. So there has been several questions about what are your thoughts on running as an exercise? Well, if you've run marathons and you've been a runner all your life, then clearly that type of exercise is something that your body's used to, and it will react in a very different way. Now, there may be changes that you need to make in the frequency or whatever of that exercise, but that's, again, something that you can talk to a medical professional or your functional professional naturopathic nutritionist, and they can address those and say, well, maybe you need to combine this with this. With regards to some of the questions that we've had on natural versus HRT, for me personally, and I believe that Dr. Jivraj has made this absolutely clear, it's not a if or but, it's not a choice between one or the other. It's about finding the right thing that works for somebody. So if I have a client who's particularly got severe symptoms, natural takes a while to get a rebalance. You have to work on it, and you have to be committed to making the right changes. Whereas if you went to Dr. Jivraj as a consultant gynecologist, she could give you something that's going to work much more effectively, much more quickly. And therefore, if you work with a functional practitioner who works with a medical profession and is properly registered, then you get the best of everything, and probably a vastly better result for you as an individual, because you're getting that balance immediately. You're combining the lifestyle and the nutritional choices, and over a period of time, your doctor will say, okay, well, I think you're okay now with your blood, so I don't think you need to do the HRT or the suppositories or the sprays or the hormones, because your body is dealing with trying to attain that balance. As for individual questions on herbs and things, that it's very complex, because as Dr. Jivraj and both have myself have mentioned, it's really about finding contraindications. So when dealing with a client, a functional practitioner will say, well, what other medications are you taking? What other supplements are you taking? And not only can one other supplement counteract another supplement, but if you're taking medications regularly, so for example, I'll give you one that's random. If you're taking a blood thinner, or if you're taking an aspirin because you need to thin your blood, and then you're taking too much ginger, that's a double whammy, because ginger is also a blood thinner. So you need to have some kind of caution, and Dr. Google doesn't always give you the right answers, because Dr. Google actually sometimes is very misleading, and people post things that really aren't medically, scientifically or otherwise proven. finally, just one that I can answer very quickly, but it will be in the handout, is the ratio for omega-6 and omega-3. Omega-3 is the compound that actually is mostly anti-inflammatory. So the ratio that I said was 4:1. So you should be eating 4 times more omega-3 compounds than omega-6 compounds. So a handful of nuts a day is probably more than enough for you to eat in a day to give you the omega-6. Omega-6 eaten in too higher dosage can actually, in food compounds, can actually lead to inflammation in the body, depending on what other compounds you're putting in there. So where a lot of people might not eat, for example, salmon or oily fish regularly, they may eat nuts every day and lots of them. So it's about trying to get that balance between the two and making sure that you're eating 4 times more of the omega-3 than the omega-6.
Great, thank you so much, Farah. So we have some rather specific questions also that I'm going to direct now to Dr. Jivraj. A reminder, please, to get onto Menti. We'll put the number again in the chat, so please do ask questions, give us your feedback as well before leaving us. So Dr. Jivraj, we've got a couple of questions that I think would be really good for you to reflect on and give us your view, please. The first one really is very much about you've covered this a little bit, about the side effects of HRT, its effect on breasts in particular. Is there anything that you wanted to add that you didn't manage to cover in the presentation about side effects? And linked to that, particularly just kind of a link into dementia and whether there is any, any sort of link up with dementia and taking HRT.
Sure. So when someone starts HRT, it's not uncommon to have a bit of breast tenderness, as there's estrogenic stimulation of breast tissue. So that's a very common side effect. If you find that that's a side effect, then your doctor will try and reduce the dose of estrogen in the combination of HRT that you're taking. Or if you're taking estrogen alone, then they will try and reduce the dose of the estrogen that you're taking or split the dose. There are other side effects of HRT which relate to both estrogen and progesterone, such as the feeling bloated, fluid retention. Sometimes some people get abnormal vaginal bleeding in the initial stages of taking HRT. And that's not uncommon. So it's not uncommon to get irregular bleeding for the first 6 months of starting HRT. But any abnormal bleeding that persists after 6 months should be investigated. So do not ignore bleeding that has persisted after 6 months. That needs investigating.
There was a linked question actually around bloating, and I think what we're doing is we're alerting people to certain things that may come up, and if some of these things persist, then we ought to go and seek medical advice.
Absolutely. And you see, HRT is not just one homogeneous treatment. There are combinations of HRT. There are generally speaking, 2 different types of estrogen in HRT, in different brands of HRT. In the UK, we tend to use 17-beta estradiol, but there's also conjugated equine estrogen, which tends to be used more commonly in North America, but it is available on the market here as well. The second thing is the progesterone component of HRT. There's different types of progestogens in HRT, a lot more different types than there are estrogens. So there isn't a one-size-fits-all. And often with HRT, it's trial and error in the initial few months to see which one suits you before you settle on it.
Thank you.
In regard to your question on dementia, then dementia is linked with an early menopause. By an early menopause, I mean a menopause before the age of 40. Now, I specialize in that aspect of the menopause. I look after women in a specialist clinic known as the Late Effects Clinic. And essentially, these are women who've undergone an early menopause for a variety of reasons. Some of them naturally, some of them because of childhood cancer treatment. And they've now grown up into adulthood, naturally menopausal already. And So for women who've developed an early menopause before the age of 40, there is a risk of early onset dementia. That does not mean that giving HRT prevents dementia from happening. There is no proof. It might not. But at the moment, there is no reliable research to say that HRT will prevent dementia. Having said that, women who have an early menopause before the age of 40, it is strongly advisable by the British Menopause Society, the International Menopause Society, the North American Menopause Society, the European Society of Human Reproduction and Embryology, and NICE. All of them are aligned with the recommendation. If a woman develops a menopause for whatever reason before the age of 40, then provided there is no, they should be given HRT at least until the average age of the menopause of the general population, which is 50. Because then they are then similar to the rest of the population, and at the age of 50, then they can make a decision whether they wish to continue their HRT or not. But certainly, early menopause and dementia, yes, there's a connection. Early menopause, be careful, is only menopause before the age of 40, not after the age of 40. And thirdly, at the present time, there is no evidence that HRT actually protects against dementia. HRT given before the age of 40 to these women protects against early onset heart disease, definitely protects against osteoporotic fractures, but no proof that it staves off dementia.
Thank you so much. Okay, I will take just one more question, but before I do, I want to thank everybody who has participated today by listening, taking notes, asking questions, and perhaps reflecting on your own personal situation and thinking about what different choices you can make. And Farah has challenged us to do something different that will assist us in this part of our lives. So please take the challenge. There are questions that are quite specifically about particular medications, which I don't know that I necessarily want to raise here, but these are particularly both related to PCOS, for example. There's a question also about Femara novatis. Is that also a type of HRT? And what if you've been offered one type of medication and actually you're not getting along with it? So to those types of questions, Dr. Jivraj, what would you suggest if people are not sure about one type of medication over another?
So clearly, if they're unsure, it probably is that they are having side effects. And I think if they're having side effects, they need to address this with their GP. And what normally happens in the UK, most HRT is prescribed in primary care. Mm-hmm. But when there is struggle in actually managing the menopause in primary care, that's when you get referred to a menopause specialist. So your GP might be able to help. They might be able to tweak the HRT brand, might be able to use a combination of different estrogens and progesterones to try and give you your HRT with minimal or no side effects. Femara novartis, I would have to check on that. I don't know the answer offhand. What was the other one?
There were a couple of things related to PCOS, and they are... sorry, somebody's coming in there. There are particular ones, so I'm going to try and pronounce this, spironolactone, for hormone balance to support PCOS, versus BC, which is
I can see that on the chat. I have not come across any piece of work or evidence or research to be able to answer that question, that this can help into the menopause. Okay. I have, Shaynaz, come across in the chat one question where somebody asked, they are on Bajifem.
Bajifem, I was going to ask,
Can they take it indefinitely? The answer is yes.
Okay. Lovely.
Carry on taking it, but remember, if you get any abnormal bleeding, then that needs to be checked. But otherwise, absolutely, you may do so. Yeah.
Okay, wonderful. So I would like us to now officially close, if that's okay with everybody. Thank you so much, as I say, for all the interactions. We do like to receive your feedback, as I've mentioned a couple of times, and we will gather again for Sisterhood that the Women's Portfolio leads on. We will also be back as a team when we think about the next subject of fertility. So look out in Al Saha for information about that topic. So we wish you all a very lovely Sunday afternoon, a great week ahead. Please, everybody, stay safe, stay strong, and be good and kind to yourselves and to each other. So Khudafis, and thank you.